Welcome to Intended Consequences, the official podcast of the Strategy Core Institute of Public Policy and Economy. I'm your host, Mitch Davidson. Today, I'm joined by Dr. Bob Bell. Dr. Bell is an internationally recognized orthopedic surgeon, clinician scientist, and educator with more than 40 years of experience in healthcare. Most recently, he served as the top civil servant in the Ontario Ministry of Health and Long-Term Care as Deputy Minister from 2014 to 2018. Prior to this, he was President and CEO of the University Health Network Hospitals in downtown Toronto, and before that, CEO of Princess Margaret Hospital. He's one of Ontario's premier health experts. Dr. Bell, thank you for joining us today.
Mitch, it's a pleasure to be here. Thank you for the invitation.
So I haven't seen you in a few years, but really appreciate you coming by. And obviously, if we're going to have a podcast about the state of healthcare today, I think everybody's going to want to talk about one thing. So we're going to go ahead and start with that, which is the coronavirus. Obviously, most serious in China and in the affected Wuhan area, but Ontario's had a few cases of its own, I think up to 3 now at this point, and more people are being screened each and every day. So even though the risk remains low, the first question I just kind of wanted to ask you, given your experience as the top civil servant in healthcare for a number of years, how would you evaluate the response by the government of Ontario so far?
Well, of course, that's in everybody's mind right now, Mitch, understandably so. We've all got a lot of concern for what the people in China are going through, Wuhan province, obviously. But if we look at what's happened in Ontario, it's been interesting. If we just look at the first case that was diagnosed in Ontario and contrast that to 2003 and look at the diagnosis of the first patient with SARS in Ontario, dramatically different. The first person diagnosed with coronavirus was under observation by public health, having been known to have come to Ontario from Wuhan, was self-isolating, and called public health to let them know that he was developing symptoms of coronavirus infection. The EMS, the ambulance folks, were warned about the diagnosis and went to pick the patient up wearing appropriate protective equipment. They brought him to Sunnybrook Hospital, where, again, people were aware of the risk and the potential for a coronavirus diagnosis and treated the patient appropriately with isolation in a negative pressure room with personal protective equipment for all staff who are encountering him. Now, contrast that to what happened with SARS, where a patient who came from China did not know that SARS was evident in China at the time, came to, of course, an emergency department in Scarborough, spent quite a long period of time in the emergency department where several patients were infected, several staff were infected, nobody was wearing personal protective equipment. He was admitted to the hospital, and as I remember, patients in the hospital were also infected. So I'd say that the state of knowledge that exists in the Ontario health system, especially in our hospital system, but also in our ambulance services, our community clinics, having been through SARS with such a major impact on our system and on this city, having been through preparation for H1N1, having brought through preparations, risk assessment for Ebola, this has all had a very positive impact on risk management and awareness of infectious disease, and the essential assumption that we have to assume that any patient presenting with an upper respiratory illness could have something that's transmissible and needs to be treated in an appropriate way. So I'd say that the entire gestalt of the healthcare system has changed since 2003. And both our healthcare workers and people in Ontario and patients are much better protected than they were back then. So
in 2003, you were at Princess Margaret Hospital, and then you mentioned H1N1 and Ebola would have been more when you were in the civil service side of things at the Deputy Minister's office. So how fast does that information flow once there's a expected case or a potential case, and what kind of safeguards go into effect at all the hospitals, not just the one where that patient may be presenting an illness?
Well, during H1N1, the risk that demonstrated itself from H1N1, I was actually the CEO at University Health Network. And because our program there had such a major expertise in respiratory medicine, respiratory surgery, we were really the organization, the hospital that was prepared to accept patients with severe H1N1 infection. So a huge amount of work, preparation done in terms of ventilatory support, preparation in our critical care units. In terms of information spread, SARS taught the healthcare world a lot, as did Ebola, as did H1N1. And that is that the most important thing we can do to protect workers, to protect patients, is to share accurate information quickly, and I'll repeat, accurately. Understanding the symptoms of a new disease, understanding the genomics of a new virus so it can be diagnosed in the laboratories as quickly as possible. These are things the whole World Health Organization has emphasized, and aspects that have certainly influenced health in Ontario. Our experience with SARS has made us critically aware of the importance of public health, of the importance of rapid diagnosis, and the importance of accurate information spreading readily.
So SARS taught us a lot about how to deal with coronavirus today, or other types of illnesses that may present themselves in the future. But what's sort of the next step? So that's been the initial screening of patients and maybe some of the quarantine practices. But where do you see coronavirus going from here? How do you see the healthcare system continuing to react to that? Is this a slow fix where eventually more and more patients are cleared and there's no more diagnosis? Or is this something where you have to remain vigilant for months and months on end just in case it does come back?
Certain parts of the healthcare system have to remain vigilant forever. So our emergency departments, for example, during Ebola, we put plexiglass screens in front of every triage area in every emergency room of the province, so that our staff sitting there triaging patients who come in are protected from droplet spread from potentially infected patients. So there's been a substantial engineered change in the way that we reduce the risk of infectious disease transmission in our healthcare system. But when you talk about next steps, this is a global issue. Healthcare today is global when it comes to infectious disease. And when we think of the development of diseases, for example, like Ebola, developing in areas that are often war-torn, developing in areas that have poor baseline health available for their citizens, we have to recognize that, just because we have access to a great healthcare system in Ontario, because we're economically advantaged in Ontario, we really have to think about the global aspect of health risks and recognize that we're all related. We all have risks from the same illnesses, and what happens in Wuhan is of concern here in Toronto. What happens in the Congo is of concern here. So we have to be global in our consideration of health.
And so part of that kind of sounds like always being prepared here at home, right? And recently with overcrowded hospitals, is obviously hallway medicine has been an issue that the Premier today has been talking a lot about, but the government more generally. CBC recently reported that half of Ontario's hospitals are over 100% capacity for at least 30 days of the last 6 months. It's a pretty jarring figure for a lot of people. How does an overcrowded hospital further complicate a situation like a coronavirus or another infectious disease?
The biggest risk for infectious disease from hospital overcrowding is that our emergency departments end up being overcrowded, Mitch. So when we have patients who need admission to the hospital who can't rapidly go up to the wards and are held in the emergency department, so-called admit no bed situations, this puts people at risk in the emergency department because staff, of course, have to care for those patients, and because the physical space available for caring for new patients is reduced. Now, the cause, well, I think it's pretty clear what the cause is. The capacity of our healthcare system simply hasn't kept up with the 4% growth in Ontarians over the age of 75, who are, of course, the people who need our health system the most. So when we consider, the causes of hospital overcrowding, it's pretty fast to get to the issue of what's called alternate level of care. Patients who are in hospitals who don't necessarily need to be there for health reasons, but who don't have somewhere to go in the community that's appropriate. Quite often they're waiting for long-term care beds. And when we look at the capacity of the Ontario health system over the last 5 years, it probably hasn't grown sufficiently to match this growth in our senior population.
So this issue of hospital overcrowding, healthcare is always an issue in every election. It's always an issue for politicians. So no surprise that it was healthcare more generally was an issue in 2014. But hospital overcrowding really wasn't at much of an issue going into the 2013-2014 period. It really started to creep up shortly after that. So you mentioned aging. Obviously, that's part of it. But were there any particular reasons in your mind why the hospital overcrowding situation either A, got so much worse in that period between 2014 and 18, or B, people started to pay attention to it for the first time?
So I think, certainly when I was deputy minister in 2017, we realized, talking to hospital leaders, talking to the Ontario Hospital Association, that the flu season in early 2018 was going to be a particular challenge. Now, flu always increases demands on hospitals. It's a perfect storm in that the first quarter of any calendar year is a time period when, Canada has snow, so seniors slip and fall and they fracture their hips, they fracture their wrists. So flu increases demand on hospitals, winter increases demand on hospitals. And, after Christmas, surgeons are trying to catch up on their waiting list because usually hospitals reduce their activity for a week or so. So it's a perfect storm of factors that actually increase demand on our hospital system early in the calendar year. In 2017, we realized that hospitals were becoming increasingly challenged, that emergency department statistics were showing poorer wait time performance, and the ALC rate was going up. I think in 2017, the end of the year, the ALC rate was approaching 13% or 14%, and that was a number I watched like a hawk, because the ALC rate, rather than the hospital capacity or occupancy rate, is far more accurate. When you work in a hospital, when you've run hospitals, the occupancy of a hospital goes up and down through the week. I mean, on Wednesday, virtually every hospital in Ontario is extremely crowded because that's the busiest elective operating day, and people who are having elective surgery and need to stay in hospital for a couple of days are there for Wednesday night, Thursday night, Friday night. They tend to get discharged on the weekend, so occupancy goes back down on the weekend. Having said that, we were recognizing that all hospitals were getting over 100% occupied during their busiest stages, and some of them were actually staying with that high occupancy on the weekends. How you measure occupancy is tricky. And, I'm a little worried that the government could declare success here by changing the definition of occupancy. That's certainly a risk. For example, patients who are admitted to hospital waiting for a bed in the emergency department have typically been counted as not having a bed, so being over capacity. I understand that some hospitals may be asked to change that definition currently and include those patients as having conventional beds in the emergency department. That would be a terrible mistake for the government to make, to change the definition on the issue that seems to be the highest priority issue for them in terms of improving access to hospital resources for Ontarians. What does the solution need? Well, this is not rocket science. We have patients in Ontario hospitals who don't need to be there. Probably today, as many as 15 to 20% of the beds in Ontario hospitals are occupied by people who don't need to be there. What are the solutions? Well, home care is one solution. So-called transitional care, where patients waiting for another resource and community go to a facility that offers them reconditioning, rehabilitation, the opportunity to get home. And about 30 to 40% of those people who are otherwise waiting for long-term care will indeed go home. And of course, we need more long-term care in Ontario. There hasn't been a new long-term care bed opened in Ontario for many, many years. And, you know, the former government identified 5,000 licensees in 2017. None of those licensees, to my knowledge, have now proceeded to start construction. They haven't been approved for construction yet. The current government talks about 15,000 beds coming on board, but, you know, we need to have beds opening. And that's a tricky issue. It's hard to build long-term care in Ontario. It's an area with we all want our seniors to be looked after well. There are many, many regulations in the Long-Term Care Home Act that make it a somewhat tedious chore to get approval.
Yeah, so going back to my time in government and in opposition to long-term care issues is one that came up again and again and again. And one of the challenges you inevitably have is the size of the budget, right? The cost of some of these things. Not only does long-term care government helps fund the construction of, but then pays per diems for the people that are in that care once the beds are operational. So I wanted to shift gears and ask you a little bit about the budgeting of the Ministry of Health and what it's like running something of that size. So, you know, the budget this year for 2019-20 is supposed to come in just under $64 billion with a B. That number is larger than a lot of provinces' total budgets combined. What's it like running a ministry of that size, ensuring value for money, and trying to squeeze more dollars out of a system that at times desperately needs it?
Yeah, that's a great question. I mean, it sounds rather intimidating, $64 billion with a B dollars. Having said that, you know, we spend about $5 billion on long-term care, for example. And that is divided up into 4 individual packages of funding. I can tell you exactly what each one of those accounts for. And no long-term care operator gets any of that funding unless they can demonstrate, for example, in the NPC budget that a patient has received nursing care that day. Hospitals have a $16 to probably now $17 billion budget. And, you know, that budget is divided into quality-based procedures that are volume-based. If you don't do that total hip replacement you're budgeted to do, you don't get it. So players in this system are very responsible. Our hospitals, our long-term care operators all know how they get paid. They know the value they need to produce, and they know the volume of work they need to produce. Physicians are paid for the most part on a fee-for-service basis. Surgeons get paid when they do surgery, etc. So budgeting is a matter of determining what resources Ontarians need. You're absolutely right. It's never quite enough. But also recognizing that the value of those services is extremely important, and you need to make sure that each one of those services is delivered. But people don't get paid until they deliver service in most cases in the system. And, you know, having worked in Ontario healthcare for 45 years, the values that people that work in this system bring to work with them every day are extraordinary. They want to do the best, and they're the best assets that Ontarians have in running this health system. They're the best allies that the deputy minister has. The phone calls that you would get from parts of the province, from Windsor, from Kenora, from various places saying, here are the problems I'm having, would always be conversations looking for solutions. And they wouldn't be leaving the solution up to the deputy minister. They'd be asking for help to implement the solutions that they knew were right for their community.
So as we sort of approach closer to the end of the podcast, I wanted to ask you a little bit about the developing health administration system in Ontario today. So currently the Ford government has come in and created Ontario health teams. And for people who are listening, that's everybody who provides health services in a geographic area is being measured on that patient's journey through all of the services, whether you're a hospital or home care or some other form of care, and being funded accordingly. Do you think that OHT, the Ontario Health Team system, can work? Is it set up for success? What do you think some of the immediate challenges are going to be facing new Ontario health teams as they get up and running?
Well, so I guess the best way that I can describe my views on Ontario health teams is they're necessary but not sufficient. And first of all, I challenge one thing you'd say, and that is that they're set up in a geographic context. Because, you know, the system that was here before, the local health integration networks, had a geography. And your postal code within that geography determined where you would look first for health services. If you wanted to go outside your LHIN, you could do so. But the LHIN was responsible for determining whether the health services were sufficient for your needs. Now, the new Ontario health teams, you know, one of the biggest concerns I have about the structure is it's difficult to tell who they're serving. It's difficult, you know, they do have the very positive feature of integrating community, hospital, mental health services with primary care services and home care services. This is positive. This is absolutely necessary, but again, not sufficient. The first thing is, what is the responsibility and accountability of the Ontario Health Team to look after patients who live in what geography? And that's entirely unclear. Some of the Ontario health teams that have been approved by the government have as few as 8,000 patients that they seem to be responsible for in their applications that have been accepted by the government. This is not the way that regional planning of health services should work. People providing health services to a region should understand who their accountability extends to, and people need to know who's going to provide services. So integration of community resources, primary care resources with hospital resources, with mental health is essential and necessary. But we also need a regional approach that says, here's how this geography of patients is going to be served. Now, I think that that is probably going to be the responsibility of Ontario Health. They have maintained, they've collapsed 14 LHINs to 5 LHINs, and, you know, I don't know the right number, nobody does. I would probably go with something a bit more than 5 regions. It's hard to think that Kenora to James Bay can be served by one region planning healthcare services. That's such an enormous geography. However, there's at least a recognition that regional expertise should be part of what Ontario Health will engender. You can't make decisions for healthcare for 14 million people from Queen's Park. It's simply too big a province, too populated to have one health region. It's not entirely clear to me where the division is going to be between the 5 health regions that I believe the government has said are temporary and the now only 21 Ontario health teams that have developed. That's hard to see. And it leaves us in a period of tremendous flux. Who is responsible for making sure that Windsorites have the services they require? I'm not sure. Is it an OHT? Is it a region run from London? Is it Queen's Park? The lines of hierarchical decision-making, the lines of accountability have been ruptured. The dissolution of the LHINs has broken them. It's not clear to this point what's in its place. And the thing that particularly concerns me is we recognize, and the Premier has been eloquent in describing the need for technology in healthcare. The fact that Ontarians want to be able to get service over their cell phones, they want to be able to make appointments with, you know, mobility-driven devices, they want to get access to the health information. This cannot develop OHT by OHT. We can't have 50 different digital health policies in Ontario. We need to have a consistent Ontario policy to digital health. And I don't see that developing as a digital statement that serves all Ontarians, nor do I see the structures that would allow that to roll out.
Well, you're also in a situation, too, where, given it's healthcare, you don't have any transition period. People are going to be showing up at ERs or clinics on a daily basis, and that's not going to change no matter what you're doing behind the scenes administratively. It's not like you're the school system where you have the summer break to figure out how you're going to do something different, right? Yeah. You've got to consistently move. So as we get right to the end, you know, the entire career to this point, or certainly in the Deputy Minister's office, has been a very nonpartisan focused role. But recently you've come out and engaged a little bit more on the political side, endorsing Stephen Del Duca for Liberal leader in Ontario. So is just to ask you why the change to partisan politics sort of more openly, and why the endorsement of Mr. Deltagu in particular?
You know, Mitch, I've worked in Ontario healthcare for nearly 45 years. Lots of opportunities to go elsewhere in the world to practice medicine, but Ontario is my home. 7 of my 9 grandchildren live in Ontario, so, you know, I'm an Ontario healthcare guy. And I have to admit, you know, having left the deputy minister's office, I wasn't expecting to be very discouraged about our health system 2 years later, but I found myself extremely worried and discouraged. Some of the changes that have been made in precipitous fashion. You mentioned the fact that there's no break period in health. When we merged the LHINs and the CCACs to provide home care, we spent 9 months doing that, ensuring that no home care visit would be missed and that everybody knew who their employer would be. Some of the changes that have occurred, for example, I'm a cancer surgeon by background. One of the things that everyone has been proudest about who works in this healthcare system is the leadership of Cancer Care Ontario in driving improvement both in our cancer system but in other parts of the system by bringing cancer-related values to health system delivery. And to have Cancer Care Ontario relegated from being an agency reporting to the minister to being a business unit in Ontario Health and having that announced in extremely disrespectful fashion, these are the kind of changes that have occurred in our health system just in the last, I guess, 20 months that have made me concerned about the future of Ontario healthcare. And, I've been nonpartisan all my career. I've been careful to be nonpartisan. But at this stage, at some point, you got to stand up and be counted. And I think the changes that have occurred in our health system are negative. I think some of the changes that are occurring in our education system, public education system, are negative. I think the respect for the institutions that have made Ontario great, publicly funded healthcare, public education, the respect for those institutions has been damaged. And, for me, not naturally a member of any parties, but I have supported Stephen Del Duca. I think, from his time that I observed him in cabinet, he's an effective politician. He's been a politician for a long time. He knows how things work. Politician to me is not a dirty word. I have tremendous respect for the work that goes into being a politician. And Stephen knows how things happen. He knows how things get done. He knows what he doesn't know. He said to me, look, I need your advice on healthcare. I'm not a healthcare expert. And I think probably based on the party ballots that were cast this last weekend, he's in a very strong position to provide leadership to the Ontario Liberal Party. And I look forward if he asks for providing him with advice on how our healthcare system can evolve.
Well, that's the perfect segue, because I was just going to ask you, what's next for you?
I don't know. My operating time at Mount Sinai Hospital is gone, so I can't go back to being a surgeon. Who knows? I'm having a lot of fun giving advice to various folks about a variety of things in the healthcare system. I have to tell your listeners, they need to go out on Amazon and buy a novel called HIP. HIP, a novel by Dr. Bob Bell. You can buy it on Amazon. All proceeds go to the Princess Margaret Cancer Foundation. And I have thoroughly enjoyed becoming a novelist, writing fiction. Second novel will hopefully be out for next Christmas. So I'm having a lot of fun with things, having worked a 7 to 10 job for many, many years. It's kind of fun to be able to spend time with my grandkids and spend time doing some things that are just different. So that's what I'm thinking now.
And I think donating the proceeds of the book to the healthcare system is a nice sort of fitting tribute to the way that you operated before, pun intended on that one. So really appreciate you coming in and taking the time and giving us some insight into the healthcare system, and look forward to speaking to you again soon.
Mitch, thank you very much for this time. It's been fun.
Thank you for listening to Intended Consequences, the official podcast of the Strategy Corps Institute of Public Policy and Economy, produced by Sarah Bordeaux and myself. Views expressed during this podcast are not necessarily the views of Strategy Corp. All rights to this episode are reserved, and guests on the podcast may be current or past clients of Strategy Corp. To find out more about the Institute and to subscribe to our written material, or to find past episodes of the podcast, please visit our website at www.strategycorp.com/institute. Until next time, I'm Mitch Davidson.